Good day. My name is Paul Wischmeyer, and I'm a professor of anesthesiology and surgery at Duke University. And it is great to be here today talking to you about delivering nutrition in your obese ICU patient. Briefly, these are my alignments. I'd like to think of them as alignments of interest rather than conflicts. I think all of us in these groups are working together to improve patient outcomes. I think when we think of malnutrition, so often we think of images like this. Many of you may recognize this photo. It won the Pulitzer Prize in 1994. It's the picture of a child crawling to a Somali food camp about a mile and a half away. No one knows what happened to this child, but what we do know is the photographer sadly went on to commit suicide because of the starvation and malnutrition and other tragedies he saw at the time. And so often this is the face of malnutrition we think of. But the reality is this is malnutrition as well. This is a Mexican gentleman, a man from Mexico. He's the world's most obese man, purportedly. Now, he's lost 500 pounds since this picture was taken, and he's gotten married. But again, this is not good nutrition either. Both are truly malnourished. And again, when we think about obesity, I think for those of you from around the world, you often think that this is a US problem because of all the McDonald's we eat and all the other bad foods that we eat in the US. But unfortunately, we've imported our bad foods to other countries like Europe as well. And in fact, now it's even reached Africa. And malnutrition-related diseases, in particular high BMI or obesity, are major causes of disease in the world. Of the top 13 causes of disease burden, nutrition-related diseases make up more than half of these illnesses. But unfortunately, the majority of the money goes to other things, malnutrition getting the least amount of funding, although causing, in many cases, the most amount of deaths and disease. So this is truly a neglected disease, and one that often manifests itself as often in obesity as it does in the typical cachexia we think of. Is nutrition vital in the obese patient, or should they be on a diet is often the question we ask. And so to try to answer that, the goals are, let's try to discuss caloric need and how to measure that. Should we use hypercaloric nutrition? How much should we give? Does one size fit all? And is there new data in COVID-19 patients that can guide us in obese patients? So how do we predict caloric need in obese patients? Well, our ICU nutrition guidelines from ESPN and others recommend we should use indirect calorimetry. And this is true even in COVID patients that we should be using this. And in fact, we've got data that shows that using indirect calorimetry may reduce mortality, at least in studies that target calories using it. But we've had many limitations with indirect calorimetry in past older devices. We were limited by many things like the FiO2 and the skills and the abilities of the operator. So they've not been used because often these carts are big and time-consuming and expensive and not very accurate. But that has all changed. There's a new metabolic cart that all of you, I hope, will have at your bedsides soon. And this device was tested and validated in a study myself and other names you'll recognize on the screen, published last year, showing this new metabolic cart is a whole different world. It's accurate, it warms up rapidly, you don't have to calibrate it every day, it self-calibrates. It's very simple to use and affordable. And it measures rapidly in 10 to 15 minutes. So this is a whole new world of indirect calorimetry. So if you don't have one, get one soon, please. But if not in the obese patient, the Penn State equation has been shown to be the most accurate in obese patients, modified in the elderly group. And so this is the equation you should consider. What do our guidelines say about how to feed patients? Well, the ASPEN guidelines, for instance, say target 65 to 70% of indirect calorimetry needs, although there's not much data for that. Otherwise, use 11 to 14 kcals per kilo for BMIs of 30 to 50, and then 20 to 25 on ideal for BMIs over 50. And so these are what our recommendations have been, but again, not based on that much data, expert consensus really. What about hypocaloric feeding? Does this make sense? Well, I will tell you, even the TV doctors know the data for this don't really bear out us using it in routine practice. This was the study, and this was an important study, but it looked at one 40-patient retrospective trial where they didn't even actually deliver the protein they had hoped to deliver. And so there were many limitations to this study, and lots of conclusions are drawn from it, but this was a very limited study, and it didn't change outcomes significantly either. So I would advocate that we don't have data to say that hypercaloric nutrition or putting patients on a diet makes sense. But maybe we already are hypercalorically feeding all our ICU patients, especially our obese patients. And is that a problem? Well, we know from Darren Hyland's International ICU Survey that in patients surveyed around the world, and ICUs around the world, we feed about half of our patients' caloric needs, whether they're obese or not, for not just a few days, but for the first 2 weeks. And in fact, we give a third of the protein they need for not just the first few days, but the first 2 weeks. This is even worse in obese patients. Patients that are lean or have low BMIs get about 20 kcals per kilo and just under a gram per kilo. But obese patients average 8 to 9 kcals per kilo and 0.4 grams per kilo of protein for the first 2 weeks of care. This is a tragedy. This is starvation. This is truly iatrogenic starvation and cannot be accepted. And so we all underfeed. This is my now 10-year-old. When he was 3, he's very well fed. But does it matter in the obese patient? And does it change outcomes? Well, let's first look at the metabolism of the obese patient and trauma patients. Well, we know a lean trauma patient who comes into your ICU can get 61% of its resting energy expenditure needs from free fatty acid mobilization. They can mobilize fats very efficiently. That's one of the reasons they're lean. But obese patients are not able to do this. They use their muscle mass for energy. They can't get to their fat stores. They only utilize 39% of free fatty acids as resting energy expenditure, and they break down the muscle for the rest. And that's one of the reasons they're obese. They're already inefficient at using fatty acids. When they become injured or ill, things get worse and they break down muscle much more rapidly. So obese patients cannot do this, cannot use fats. They don't break down their own fat. Putting them on a diet is not going to make sense. They're just going to waste more muscle. So again, they cannot utilize fat for energy, even though they have large fat reserves. And so they lose muscle mass much more quickly. Does giving calories and protein back to these patients improve outcome, to the obese patients in particular? Yes, and we have the data. Again, this is the International ICU Nutrition Survey. This is almost 3,000 patients. And what we found was in patients who have high BMIs, or in all-comer patients, giving more calories does lead to reduced mortality. These are all patients. In lean patients, as you might guess, with BMIs under 25, the more calories you give over the first 2 weeks, the better survival you get. People with middle BMIs, 25 to 35, the caloric delivery over the first 2 weeks doesn't make as much difference. But when you get to high BMIs, there's again a significant effect of delivering calories there in the purple line and the green line to improving mortality. So in obese patients, it does seem to make a big difference. And every 30 grams per day of protein you give, you will also decrease mortality. And so obese patients need kcals and protein just as much as the lean patients do. And so this data is compelling. And again, it's important to realize that although early in care, we may not need as many glucose calories, we definitely need the protein calories. And so again, as patients age, they get anabolic resistant. It takes more grams per protein per day to get them the protein they need to generate. So it takes more grams per protein to generate the same amount of muscle as we age. But in critical illness, this gets much worse, and we'll probably need to use other interventions like oxandrolone and propranolol to actually get patients to gain muscle because they're very anabolic resistant. And again, we have good mortality data for as we give more protein. This was a large study by Pierre Singer. The mortality continues to decrease as protein levels continue to increase throughout care. And then finally, does it change patients' long-term outcomes? Are we creating survivors of our patients or victims? We know from, this was from the Redox study, and these are patients that are on the ventilator more than 8 days, like our COVID patients. If we give 80% of calories or more, the survival is better than if we give less over the first week. And again, we had quality of life scores in these patients, and every additional 25% increase in protein and calories we gave, we improved quality of life months and perhaps years later. And so again, how you feed in the first week in ICU changes patients' quality of life much later, and we think this ties back to protein. Additional protein improves quality of life from this data. So for protein requirements, our ASPEN guidelines say that patients who have a BMI of 30 to 40 need 2 grams per kilo on ideal body weight, and patients with a BMI over 40 need 2.5 grams per kilo on ideal body weight. So be sure they get their protein. So a brief overview on how to feed patients with the data that we've had up to this point. Is hypercaloric feeding appropriate? Only in early shock or the acute phase, and that's where the 11 to 14 kcals comes in. And ideally what you want is to have an indirect calorimeter. And if you do, then you can use that and add an appropriate stress factor. If you don't, and the patient's intubated, you can use the Penn State equation. If they're not intubated or you're not using the Penn State equation, you can use Harris-Benedict, or you can use this wide range of kcals per kilo. And I think we need to narrow that. We need better research. And so what about the COVID-19 patient? Well, we are doing a study at Duke called the LEAP COVID study. Where we're looking at what the actual measured calorie needs of patients are with COVID-19. because we don't have data like this in COVID-19. This is a very unique disease, and we wanted to understand what it was. And so we're doing many measurements, including metabolic carton, muscle ultrasound, and BIA, every 3 days from ICU admission all the way to hospital discharge. And I'm going to show you some of that data now. These are the first 22 patients. This has been accepted in critical care, should be out soon, maybe this week. And as you can see, the patients that we studied were about 58 years old. They were largely African-American, more than half, and they were on average obese. So more than half the patients were obese, and that's very common for COVID patients in the US. And what we found was there was significant hypermetabolism in these patients, especially after the first week. So the second and third week had marked hypermetabolism that we saw up to 3,000 calories. And I'll be giving a lecture on this in a future session. You can hear more of this data. But you can see that in obese patients here, the BMI over 30, their average needs were 31.5 kcals per kilo on actual body weight and 32 on adjusted. These are the ESPEN guidelines. So again, significant needs, 30 kcals per kilo, 25, 30 kcals per kilo on actual and adjusted body weights in the obese patient. And they were very difficult to feed as COVID patients are. You can see we didn't get calories in very well. This is what the non-obese population looked like. Again, these are the caloric needs measured over time because there's a lot of variability. And this is measured resting energy expenditure. That red line is Harris-Benedict predicted. And so again, this is the obese population. You can see the actual in blue and the adjusted weights in purple, and then the Aspen recommendations in green. These patients were all above that throughout their care in the obese patient group. And you can see when you compare the two, there's subtle differences, but they didn't meet statistical significance. And so there's some similarities and some differences between obese and non-obese patients. So again, and there's a lot of variability. And these are people, here's Krista Haynes, and the other was John Whittle, who did this research. There's a lot of variability. So our initial results show that the first 3 to 7 days, the patients are normal metabolic or even a little hypometabolic, and then they become very hypermetabolic after the first week in COVID-19. In the first week, I think giving 20 kcals per kilo on actual body weight for BMIs less than 30 and adjusted body weight in obese patients is close to average. And then we probably should use the 70% of 20 kcals and ramp up to do our trophic and then ramped up feeding. A few other points, lots of variability. Older patients need a little less. Obese patients need a fair bit, 30 to 32 kcals beyond the first week, and fever increases this considerably. So in conclusion, obesity does not equal well-nourished in the ICU. Our patients can't utilize this fat. They can't move these fat stores to generate energy. Thus, obese patients lose muscle mass faster than non-obese. So do not put these patients on a diet. The metabolic cart is the best way to measure, and we have a new metabolic cart now. I encourage all of you to get it. Penn State is second. We need to give more protein. There is no good data for hypercaloric feeding, and we already do it already. So obese patients need calories just as much as thin patients do. And this is not the only face of malnutrition. This is as well. So we must feed better in all our patients, and hopefully we'll create more survivors of our patients and less victims, and get more of our patients, including our obese patients, back to the life they came to us to restore. With that, I look forward to any questions you may have. Feel free to reach out to me on Twitter, Instagram, or email. I'm happy to share any of these papers, and thank you for listening.